Dr. Lee, I was going to start with you. This would seem like an easy answer, but I wouldn't ask if it was. We've all been taught that when in doubt, when someone's having an allergic reaction, if our kid is, for example, or if we are, go for the epinephrine. Can't do any damage. Use it. But I think a lot of us, including myself and my wife, have been in this situation where a child's having a reaction. Doesn't seem bad. It seems like a Benadryl type reaction, if I can call it that. And we're not sure. I guess what I'm saying is I think it sometimes is very gray, and we're told that it should be black and white, but it's not. How do we know? How do you know when it's time to use the EpiPen? You don't want to use it at, see if you've got a little tingle, but we're taught always use the EpiPen. So when is the right time?
Well, actually, that's a very complicated, though seemingly simple question. Because I've been in debates with allergists where you see really completely competing views of when to use epinephrine. So actually, you do hear conflicting views, which makes it very difficult for families in general to know if you hear different authorities saying when to use EpiPen, when to not. What I tell my patients though is that we know epinephrine is very, very yes. Yeah, so what I tell my patients about epinephrine is it's a very safe medication. We know that, so that the side effects are you get a fast heart rate, it's adrenaline rush, so you feel a little jittery, it goes away very quickly. So that for children who are healthy otherwise, they actually can handle the dose of epinephrine with very few side effects. And so what I really try to emphasize is that if in doubt, really use it. And I tell this to my families over and over again. And honestly, what happens is they come back to the clinics, and more times than not, they say, I know I should use the epinephrine, I didn't. And so I really try to encourage them to use it. And then some things about the epinephrine that people don't realize is the reason why you call 911 afterwards is not that epinephrine is dangerous, but it's because you can have a rebound reaction afterwards. And so some families have this sort of hesitation to use this. And so really, when I talk about using epinephrine, I really try to lower the barrier of when to use it. And so, you might hear different things from different doctors, but when we talk to my patients, I tell them, anything more than a few highs where you feel that things are going, where things are just more than just a few highs, they look uncomfortable, you can use epinephrine. We can talk about it later in my clinic, and we can talk about whether it's really the right time to use it or not. So really, I try to encourage them to use it if there's any doubt.
And I would totally agree with that. I think the biggest issue we have isn't not when to use it, but when to use it. But getting people to use it more aggressively. It's a very safe medication. People have a lot of discomfort with both the fact that it's a needle, that you're injecting your own child, or your child is injecting himself, or you're injecting yourself. We actually have made a practice of using it. When we do food challenges and we need to use epinephrine, we usually use the EpiPens, and then part of the reason is to show people, look, here's how it works. Click, person feels better in a very short period of time, and it can be, and that condition is managed very quickly. And I always tell people, if you feel like, wow, I wonder if I should take my child to the ER with this, then you should be using your EpiPen. Because a lot of time they'll feel more comfortable going to the ER and having somebody else do it. But what you find is that sometimes the ERs should be using it and they're not. And you probably, you may be the better, sort of a person to sort of help to make that decision in some cases. So I think it's better to be more aggressive than less aggressive. I agree 100%. If there's mild, symptoms, mild, hives, then it's probably okay not to use it. But you have to have a low threshold to be willing to use it, be comfortable with it.
Dr. Hesterberg, I had this one written down for you as well. I think Dr. Etkin referred to it a little bit earlier, but we've got a family, let's say, of 2 children, both with peanut allergies. We have a new baby. What do? Do we give the baby peanuts? Do we test it? How do we wait? What would be what's the best protocol right now?
That's like the $1 million question. That's a really tough one because you're dealing with so much that we don't have complete control over, and a lot of it is what's the anxiety level within the house? What's how many kids are there? How how are those people going to be able to manage that on a day in, day out basis? But in general, I think you have to treat them as individual people. You have to, we would encourage, as they were talking about in the last group, that early intervention is really key. It's key in prevention. Better to have 1 child with peanut allergy than 2 children with peanut allergy. I think the goal would be to try to, I usually try to work with parents to find a way to introduce foods in a safe way and as early as possible. And I don't know if Jennifer has anything else to add.
Yeah, so one thing is that I really try to explain the risk. So that actually, if you screen for allergy testing for a baby that has no history of peanut allergies, you have this issues with false positive results, and that's what was talked about before. And if you have a false positive result and you start having them avoid peanuts, that actually a false positive may become a true positive result, and they actually then may have a peanut allergy for the rest of their life. There actually was a study that came out recently by Dr. Gupta in Chicago that showed that siblings of children who have peanut allergies, there's about 5% chance of having a true peanut allergy for a sibling, but about 20% of them actually will have a false positive. So actually the risk of having a false positive test when you do these screening is much higher than really detecting a true allergy. So that, I mean, in general, if the families feel comfortable, and that, like Dr. Hesterberg was saying, it really depends on the anxiety level of the family and how they feel about introducing peanuts at home. I really try to encourage that if they feel comfortable with that.
Thanks. Nurse Timmons, my question for you is, the labeling laws on all food products say they have to label in clear language which are the top 8 allergens they contain. A lot of them, there's that murky language of it's produced on a shared facility or on a shared line or made. What do you tell people about? Should we take that? I shouldn't say should we take that seriously, but are those products that we should avoid? So if my child has a dairy allergy and we're about to buy a product with no dairy, but it says, has been produced in a facility where dairy has been made on a shared line. Do we avoid those? Are those safe to go for? How should we consider that?
It's a really hard question because it really depends on how it's manufactured. Sometimes what manufacturers do is put that in because they want to kind of be safe and save themselves. But what it really means is that, something's made on this line and something is made 3 doors down on this line, and they have to, and they say, oh, it may contain milk, when they've never even crossed each other. So it's really, I tell families to call the manufacturer and find out exactly what they mean by that, because oftentimes it means that, it really is okay. But that has to be up to the family, and like John said, the anxiety level and whatever. And it's also depends on, the actual child. If the child has been eating this for 5 years and now all of a sudden it says may contain milk, well, does that mean that he can continue having it, or does it mean he can't? And there's really no easy answer for that. And unfortunately, it's unregulated. So there's really, because Nabisco does it this way and, Keebler does it that way, it doesn't mean that it's the same thing.
Were there, I think we might get some numbers on whether or not people have reactions from those, or
Mike,
are you familiar with that?
Mike, what would you talk about the study?
Sorry, I was asking if there were any. I'm basically asking if there are any statistics about whether or not those products, if they were tested, whether or not they actually showed that the allergens were contained in them.
So there have been some people that have looked into that, and the actual amount of protein is extremely low when they've gone into the factories and tried to measure. Well, specifically for peanut, when they've gone in and tried to measure. And we have been involved in a study which is, we sort of loosely call it the threshold study. It's being done at multiple sites, where we give sort of a very small amount of protein to people that have known allergy, and the amount is sort of similar or slightly more than what you find in these levels that have been found in these factories. And what they found is a very low rate of response in the kids that have actually been tested. This hasn't been published yet, so we're still waiting for a lot of the data to come in. But in our own sort of hands, we haven't seen very high rates of reactions. I think that the goal of these type of studies is just really to kind of open up this black box, figure out what we're really dealing with, because it really just is a source of anxiety for everyone.
Absolutely.
I think that, with sort of preliminarily, it looks like the risk, at least for peanut, has not been exceedingly high in our hands in people that are eating, and basically it's based on taking very small amounts of the protein, giving children a cookie, having them eat it, and sort of monitoring for symptoms, based on what's been found sort of at levels in these factories. So it's not a perfect tool. It's not, it's not going to account for everything, but it's sort of, hopefully we'll start to, shed a little light on this area a little bit.
Dr. Yuan, you have a lot of expertise in, a lot of areas, but GI areas, and specifically I wanted to ask about eosinophilic esophagitis. First of all, just 2 questions. One, what percentage of children, or I should say individuals with food allergies, have EOE? And secondly, I think the last time we spoke, there was some positive news that had come out, some progress. And I guess I'm kind of curious on the status of where we stand with finding treatments or even cures for EOE, and if there are any ramifications for the broader food allergy world.
Great. I'm the only gastroenterologist, not an allergist actually. I'm a stomach doctor. So this question is, I think, but I'm not sure whether I have the answer to know exactly how many percentage of the patients with EOE actually in the food allergy category, because there's two different categories. In the EOE is not largely mediated by the IgE. So that means all the skin tests the allergies do, not necessarily will predict what happened in the esophagus. So that's one of the challenging. How we monitor those patients with inflammation in the esophagus, we have to rely on endoscopy. The new insight, as I digress a little bit for the question, Paul, and the new advancement in MassGeneral is we developed the capsule, which is using light microscopy to scan the esophagus within 30 seconds for the entire esophagus. So hopefully that will eventually replace the conventional endoscopy. We don't have to put people under general anesthesia, so we can monitor their esophagitis. So that's there's a lot of advancement for the EOE in terms of understanding what's the risk factor. We published a paper 2 years ago looking for the retrospective study, looking for 27 children with EOE at age 5 to ask the families what's the risk factors. We asked them many different questions, including when you started the food, what food you started, did you nurse your baby, and was the child born via cesarean birth or by vaginal birth, or did they have antibiotic use in the first year of life? So the bottom line, the three risk factors jumped out independently. First are cesarean birth, simply an independent risk factor. Second is antibiotic exposure during the first year of life in children will independently increase the risk factor, increase the risk for developing EOE at age 5. Last, if you have a child has bloody stools in infancy, in the first year of life, you also increase the chance to develop EOE at age of 5. So taking that step further, we designed the prospective study, which is Dr. Schreiber just mentioned. We started 22 months ago in the primary care setting. We recruiting all children, all comers come in. Right now we reach about 700 children. So from that study, we systematically collecting the questionnaires from the parents to ask each visit what's changed for the diet, and then we collect the baby's stool, we collect mommy's stool, and also collect mommy's milk. And we're in the process trying to analyze what all the risk factors, and then what I can tell for data preliminary, we have about 11% of children in that cohort in infancy develop food allergy in EOE, which is higher than actually the IgE-mediated allergy in that age group.
Thank you. I don't know who this question would be best for, but is there research about, did I read that there's research about the benefits of probiotics in treating food allergies or anything? Dr. Yuan?
Well, we do use, the gastroenterologists are using probiotics very, very, very liberally, and it's proven to be very safe. And all the major formula companies that put probiotic in their formula. So that means you can give your babies at 1 day old, so it's considered to be safe. The question is mainly, Paul, is which one do you give? We don't really know what they're missing. And then certainly in the first 4 days of life, babies quickly acquired all the bacteria in the gut, 4 days. So if during that 4 days of period of time, if the baby has been exposed to other insults, such as antibiotic use, that will perhaps inadvertently affecting that initial acquisition. So the question is knowing what they're missing will help us certainly to direct what to give them. Right now, unfortunately, the study, the research tools only in the research arena to identify those babies, what they are, what they have. Hopefully in the near future, in the next few years, we'll be able to answer that question more specifically. That means if we can take a rectal swab from a baby, hopefully running the machine, I'll be able to know your child, your infant is missing certain species, and then I will be able to get that direct prescription for your child. Hopefully that will, I will offer some new treatment tools to change the dynamic of the gut immunology, perhaps influence the development of food allergy.
Thank you.
Yeah.
Last question on this, actually, Nurse Timmons or others. For any individual with food allergies, adult or child, if they continue, if someone continues to have mild reactions, slight hives to a food that they eat all the time, no severe reactions, would the best course, would you suggest that these individuals continue to eat those foods to hopefully desensitize, or is that kind of a danger sign that they should be a little more careful because they're reacting to a food? I guess I asked any of you
That's
to
a
jump in on
really,
that.
really tough question, and I think it really depends on the emerging research. At this point, I think I probably would tell them to continue, but I don't know what you would think, John. I think it really depends on the reaction and what's happening with that particular food. Is it just one hive on the cheek, or is it the whole face?
Right.
You know, that kind of thing.
I mean, I don't think you can sort of give a blanket answer to that. You have to really take patient history, what's been going on, if there's a history of anaphylaxis. And so, I mean, a question like that, you'd really have to talk to your own allergist about that.
Yeah, I agree. I mean, it's very individual, you know. I mean, I think that also it's not super common to have somebody just get hives with the food over and over again, honestly. I mean, you know, I think maybe more commonly you'll have people that have oral allergy syndrome, where they're getting a lot of oral symptoms or some throat symptoms with foods, and there's a lot of nuances to that. Like, you know, soy is classic. You know, where people may have oral type symptoms with soy milk, or even more severe reactions to soy milk. But I have people that tolerate other forms of soy, and it depends on sort of how soy is processed, and you know, and you have to really take it case by case to some degree. And I think we're doing more of that than we used to. I think in the old days, we used to make more blanket statements like, you know, I mean, a lot in the room might be where, you know, it's like, you're not eating peanuts, you can't have a tree nut. You know, that used to be the old, you know, advice. All nuts, forget about it. And, you know, we've gotten a lot more away from that. We're much more liberal about introducing and trying to minimize, you know, the number of foods we take out of the diet these days. And I mean, so, you know, a lot of that's individual. I think there's a lot of changing currents in sort of how we manage it. We're more aggressive about doing oral challenges. We're trying to keep more foods in the diet. And that's really been, I think, over the last few years what I've seen as far as change. Doesn't completely answer your question, but I think...
No, but it's actually, I guess what you're all saying is consult with your allergist.
Yeah.
Don't make the decisions on your own. Don't take stupid chances, for lack of a better way of putting it.
I mean, I think at both of our centers we tend to be, I mean, there's a ton of experience with food allergy. We have the ability to do challenges, which some places don't. Some community practices are, you know, we get a lot of referrals. And we tend to be fairly aggressive if we think that there's a good chance that somebody's going to be able to tolerate a food, or if it's a vital food. And we do it in a very safe fashion. And you know, it's really, I think, help people out. I think that one of the things I see a lot of is just, you know, introducing foods while an anxiety-provoking event. Once you actually get it into the diet, it reduces, you know, anxiety overall. And you know, our goal is, I think, to try to, you know, I think to just try to get more foods back into people's diets, to try to liberalize their diets as they are, to be maybe less conservative, but in a sort of, you know, with better understanding of what the safety is associated with that.
And just a quick follow-up, since you mentioned oral allergy syndrome, are there any cases where that's dangerous?
I think you always have to consider that as a spectrum. You know, it is a true food allergy. The proteins that cause oral allergy syndrome typically are thought of as being very labile proteins. They break down very easily. However, there are you know, certain foods that fall into that category have proteins that, you know, you can also be allergic to, that are more heat stable and, you know, are less readily broken down by, you know, saliva and stomach acid or heating, and can be potentially dangerous. But typically, if you get a good strong history of, you know, like fruits and vegetable, you know, oral tingling, you know, it usually is not a really progressive issue. I typically don't prescribe EpiPens if somebody just has oral allergy syndrome. It's probably one of the most common allergies I see in adults. It's, you know, typically has adult onset because at some point they're developing environmental allergies, and it's really an association with pollen that creates that syndrome.